upon Mr. Ravi Narayan. Welcome, sir. It is now our privilege to invite our esteemed faculty to grace this occasion by lighting the lamp, a symbol of knowledge, hope, and healing. So, all the faculties, please come on the dais.
वक्रतुंड महाकाय। वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
Thank you, sirs. We now invite Dr. Jayesh Lele, sir, to share his kind words and set the meeting tone.
Thank you. Good evening. It gives me great pleasure to welcome you all on behalf of Indian Medical Association, Mumbai West Branch, for this very innovative seminar. In fact, previously, somewhere in 1990s or 2000, we started with NCD, non-communicable diseases. That was an umbrella of certain diseases. But now, about 2023, I think the American Heart Association started with this terminology. It's a cardiovascular, kidney and metabolic diseases. It is found that most of the time these three occur together, and what drugs we are getting it is simultaneously are acting on more than one disease or two diseases. So it gives us help for prescribing, managing. Yeah, Dr. Ketan, he's there. He's traveled from Chennai. So it's a really a boon, and we have the great faculty, Dr. Kriplani, Dr. Mahesha, and Dr. Manoj Chadda, and Dr. Rajiv Karnik. And of course, to top it all, during the question answers and the moderating session, Dr. Ketan is there. So we will have a great discussion on all the four topics, as well as we'll have a special questions and answers, and we have incorporated today the voting pads also. I think so that will also be a kind of a innovative. Of course, Dr. Ketan and later on they will explain you how to go about it. But it is going to be a very thrilling and very informative session. Enjoy. Thank you all for this attendance, as well as thank you MacLeods for giving us the opportunity. And thank you all the faculties for sparing on Saturday evening for this seminar. Thank you.
Thank you, sir. So now we move forward for the first talk on optimizing the use of beta blocker and advancing contemporary care. We have Dr. Rajiv Karnik, sir, with us. We invite sir. So over to you.
Ketan Mehta, Mahesh, and then probably Manoj will join very shortly. So dear friends, the task given to me is about optimizing beta blocker therapy in heart failure, and then little recent advances, which may not be very much applicable to our practice because some of them are like device-based or transplantation or which we do not have and which we do not commonly practice. For practicing physicians, what would be more important is beta blocker therapy. And when beta blocker therapy in heart failure comes, I would be forced to speak on heart failure with reduced ejection fraction, because in preserved ejection fraction or normal ejection fraction, beta blockers are not so much favored. So this is a case that came to our OPD referred from a rural practice. 60-year-old male referred from rural general practitioner. And then he had significant effort dyspnea. He was already on digoxin diuretic, losartan. And then the question was, the reference was for CRT, that is cardiac resynchronization therapy pacemaker to be implanted. And it's not just a hypothetical thing. In fact, I was talking to Dr. Haigreva Rao from Hyderabad. So he said that he does a lot of implants. So he said he still gets such patients who are only on digoxin diuretic, not on any pillar or foundational treatment of heart failure, and they are just referred for this thing, CRT or device implantation. So obviously that fellow was little knowledgeable, so he had done his ECG, echo, X-ray, and then with his symptoms of progressive dyspnea, orthopnea, and bilateral edema, he saw the ECG LBBB, and he must have heard that LBBB, reduced ejection fraction, and heart failure is benefited by a CRT device implantation. So that was the reason why he had referred. Echo was showing ejection fraction of 35%, and chest X-ray was obviously, these investigations are done first and patient is examined later on. But then, dear friends, I think the most important is to examine the patient clinically, which I think we don't have Farooq Udwadias with us now, to do these things. And then many a times these things are missed. So dancing carotid and JVP, and then this typical pattern of signs and symptoms of heart failure. So those are seen little later. So basically this patient had congestive heart failure, and then he would, with his progressive dyspnea and then orthopnea, he would definitely need hospitalization. Now, how common are these things? In fact, 65 million is the expected prevalence, and then they are highly symptomatic. For example, in CHAMP-HF registry from United States, outpatient, 90%, 9 out of 10, 90% were symptomatic. 1/3 in this thing, CHAM study, HF study, had required hospitalization. And then look at the left-hand panel there, they are highly, once they get hospitalized, they are highly prone for, the various events, either rehospitalization or death, like a cradle going to the graveyard. So with the first hospitalization, lifespan is just 2.5 years, less than 3 years. And then with the second hospitalization, third hospitalization, the person is going towards the death rate. Now, we normally are very much tuned to be on our toes, whenever patient comes with this thing, ASCVD. The moment patient comes with chest pain, troponin positive, we go for GRACE scoring. And if the GRACE score is more than 135, we immediately, and troponin positive, we immediately wheel the patient to the cath lab, and then patient is immediately goes for intervention. But look at this heart failure, which is a little bit ignored commodity, that even those people who are totally asymptomatic versus this, and now this patient I am admitting who had come from the rural practice, he is with heart failure with reduced ejection fraction 35 and then recently getting hospitalized. So his death rate will be that almost more than double as compared to the highest death rate which one would get with ASCVD. But yet the people with heart failure do not get so much of attention. That's the sad part of story. Now this patient was on digoxin and diuretic. Digoxin is of course a more than 200-year-old remedy, and it is still practiced. And now again it is coming back with, although the DISH trial was not positive, but DIGIT HF and Decision and then meta-analysis of all the three is showing positive results with digoxin. So it is coming back into the practice. And then this is more than 200 years old. The first paper was with the magical account of foxglove and so on and so forth. And subsequently this theobrome, mercurial diuretics, etc., diuretics came into the picture. And digoxin diuretic was the mainstay which this rural doctor was already giving. But then look at this, what happens with digoxin or any inotropic treatment. It's like a whipping a tired horse with digoxin to go harder and harder, and which finally he would give way. And then it's not only with digoxin, but even with the inotropes, inodilators, inotropes also, you will find that if you see the mortality curves with inotrope versus diuretics versus vasodilator, finally the winners are vasodilators and not the inotropes, which was thought upon earlier when digoxin was advocated more commonly. And because it was seen that dilators are working better, because they dilate the peripheral vasculature, the heart can pump easily, and then heart can get recovery of even ejection fraction, adverse remodeling, so on and so forth. And then that's why the first drug that came for multiple trials was ACE inhibitor, enalapril, captopril. These drugs were studied. And then as you can see here, consensus was, and followed by SOLVD, SAV. So these trials came between 86 to 93, 94. And that became the cornerstone of treatment for heart failure. But soon after that, the beta blockers came into picture. Then after that, towards the end of last millennium, 1999, Brad Pitt's Ral's trial with Spiro, and then subsequently Fayez Janard's 2011 publication with eplerenone with mild heart failure. This was with severe heart failure, this was with mild heart failure. And all alike, everything showed good improvement. And subsequently, the real game changer in 2014 and 2015 was this Paradigm HF, this ARNI, and then immediately the next year, 2015, the SGLT2 came into picture, and then it showed again uniform reduction in heart failure, hospitalization, death rate, so on and so forth. So as a result of that, these drugs became the mainstay, the cornerstone of treatment. And these four drugs, which I showed you in the previous slide, like the RAS inhibition, the beta blockers, the mineralocorticoid blockers, SGLT2, and RAS blockade got replaced by ARNI. So they became the mainstay of treatment. And as you can see here, with digoxin to begin with, our oldest drug, then the mortality, the forest plot graph started moving away and away from the unity line with hazard ratio of 30, means 70% relative risk reduction of the death and various cardiac event rate. And then so many trials came with all these different drugs, and then subsequently others also. But it is like a chakravyuh, and then one has to be very tactful in initiating which drug and then what to be given. And if you see the vis-a-vis all the drugs which is more effective, then you will find that this ACE inhibitor or RB, then ARNI, then beta blocker, MRAs, and isosorbide dinitrate with hydrolysine. So the most effective drug is beta blocker, and then that is the reason why MacLeod has today decided to give more importance to the beta blocker and to discuss about in greater detail. Beta blocker was really a game changer in 1960s. 1960s, even before that, this James Black was working on it, but in 1960 he came out with it, and 62 he got the Nobel Prize, This is a Nobel Prize for that. And we owe a lot to that because after 1960s, for almost 5 decades, so 4.5 decades, beta blockers were on the top of whatever cardiac element, not only cardiac but neurological and then various other elements, beta propranolol followed by all the other beta blockers were on the real, on the top of the range. And then basically because these sympathetic neuroendings liberating epinephrine and stimulating the beta 1 receptor and increasing the cardiac muscle contraction and leading to myocardial ischemia or peripheral vasculature leading to hypertension. So for all these things, this drug became ubiquitously most important pivotal medicine, I would say. And at that time, in fact, it was thought that in heart failure, it should be contraindicated because basically it is the drug which is actually increasing contraction of the heart muscle. So to give a drug which will reduce this thing, beta blocker, which will reduce contraction, so that should be totally avoided. So giving this drug was in 1960s, late 60s and early 70s was absolutely a taboo. But somehow this Vaxtin and Gelmerson from Sweden, they had some cases with hopeless cases of heart failure with intolerable palpitations. So they decided that anyway they are going to die, so why not to give a palliative treatment with beta blocker? Just at least their palpitation will get cured. So they gave beta blocker knowing that it may not work, it may aggravate heart failure. And to their surprise, after 6 months, they became better. They started feeling better, their ejection fraction improved, and then they had all the positive results. So after that, the metoprolol dilated MDC trial came in dilated cardiomyopathy. And then that was published in December 1993. So that was the first trial which said, yes, beta blockers in dilated idiopathic dilated cardiomyopathy, it's a great boon. And around that time, one of the second pivotal trial, landmark trial, was US carvedilol trial. In fact, Milton Packer, J. Con, etc., they had to sit with FDA to convince them that in heart failure, we are going to do a trial with beta blocker. So it was in fact decided and agreed with FDA that up to 33% increase event rate would be permissible for this trial to be continued. Because anyway, the heart failure may get aggravated. So that was an agreement with FDA before this trial was started. By that time, they did this in, if you see here, in April 93. And MDC, the dilated, the metoprolol in dilated cardiomyopathy, MDC trial was published in December 1993. So this was before that they had done all the, discussions with FDA, and then that was allowed. And then they were just keeping fingers crossed that, you know, if the incidence of event rate goes up, then we may have to stop the trial. But to their surprise, the DSM board, Data Safety Monitoring Board, said that we have to terminate the trial, and prematurely. That was in February 95, within 2 years. And that was not because of increased event rate, but because of this huge benefit. The total mortality got reduced by 65%, hospitalization got reduced, as well as the death and hospitalization combined endpoint also got reduced. So this was a great surprise, in fact, with US carvedilol. And this 65% reduction in the hard endpoint of mortality was really a surprise, but then subsequently this Copernicus and Merit, this is with metoprolol, this is with carvedilol, and this is with bisoprolol. These other landmark trials came, and that proved more or less a similar thing. And then after that, most of the trials had about 34-35% relative risk reduction of this hard endpoint. This was purely mortality trial, not first hospitalization, not worsening heart failure, the very hard endpoint. There was another thing about the death, whether because the arrhythmic death, it was thought that with beta blockers, it will prevent ventricular tachycardias and arrhythmias, and it will reduce. And that was definitely proved in Merit-HF trial that it had reduced the death rate. And then if you divide this all-cause total death versus sudden death and death due to worsening heart failure. The worsening heart failure is pump failure and terminal death. Patient is admitted to our ICU with acute breathlessness, he's on ventilator, and finally dying because of heart failure. That is one. And then the sudden cardiac death. Just one fine day he is dying. So with severe heart failure, when they dissected out So all three were benefited, and it was not only in MERIT-HF trial, but even the CBIS, the bisoprolol-based CBIS-2 trial and MERIT-HF metoprolol as well as Copernicus trial, everywhere you will see, and the pooled analysis in the forest plot graph, that there is a this thing significant benefit in severe heart failure and sudden cardiac death, and that is not that is quite significant with relative risk reduction of about 40+%, and only Capricorn had slightly less, but otherwise it was there. Then the discussion started becoming, is it just a class effect and all drugs are equal, just like in SGLT2, whether you give empagliflozin, dapagliflozin, sotagliflozin, everything is equal. So is it equal or different between different drugs? So then the first was a COMET trial that was done. And in COMET trial, when metoprolol versus carvedilol was studied, they had better benefit with carvedilol, just like US carvedilol had good reduction. But then the criticism was that in COMET trial, they had used twice a day metoprolol tartarate, and which was not the drug which in MERIT-HF trial it was studied. But then probably I believe that why they had used metoprolol tartarate twice a day, because carvedilol is given in twice a day dose. So to have these two parallel arms and patient should not know which drug he is receiving, they use metoprolol tartarate which was twice a day, and then that's why this metoprolol tartarate was used and not succinate. But nevertheless, subsequently other trials also showed the same thing, and carvedilol was a winner. But then what about bisoprolol? Bisoprolol is very nicely studied in this cardiac insufficiency bisoprolol study, the CBIS studies, CBIS-1, CBIS-2, CBIS-3, there are multiple studies, but most often the study which is talked about is CBIS-2, and then that was with LV ejection fraction less than 35% in NYHA class 3 and 4 failure with to more than 2,500 people. And then you will see that there was reduction in the mortality by 34%. And this was also, just like US carvedilol trial, this was also studied, stopped early due to significant mortality benefit. And then if you put all the secondary endpoints, like sudden death, caused due to unknown hospitalization for any worsening heart failure. So everywhere you will see that there is about 35 to 45 to 55% relative risk reduction in the secondary endpoint, and especially more so with ischemic dilated cardiomyopathy, as you can see here. The idiopathic dilated cardiomyopathy, the confidence limit of this forest plot graph is very east to west, crossing the midline. But in ischemic cardiomyopathy and with class 3, class 4, I mean, it showed a very uniform benefit. CBIS-1 trial had not shown a significant benefit. P-value was 0.22, not our classical less than 0.05. But then they had done unexpected, I mean, they had estimated the event rate, and then the power for this study that was calculated was too bad, and then that's why probably they did not have adequate number of people, very less number of these things, so that's why the p-value was not. But nevertheless, there was trend of 20% reduction in the mortality and 32% reduction in the hospitalization. But this is the trial which I showed you earlier, and then there was another trial, CBIS-3. CBIS-3 trial was specifically done because this is about the meta-analysis of CBIS-1 and 2, because 1 was negative with less number of people. So if you do the meta-analysis, you will see the forest plot graph is beneficial. Now, I was talking about CBIS-3 trial. CBIS-3 trial was done to see, should you give enalapril first or should you give bisoprolol first? Because many times, I mean, we know that ACE inhibitors are the pivotal, and they came in 1986. They became the first drug to be introduced, and beta blocker became the second one. But then sometimes you cannot give this thing ACE inhibitor because of either potassium, creatinine, or this. So in those cases, can you use bisoprolol in place of enalapril? That was a question in this when CBIS-3 was studied, and then they showed that bisoprolol first versus enalapril first is here, and bisoprolol. So all-cause mortality, I mean, there was not significant difference. The p-value was 0.065, so more than 0.5. But sudden death prevention being beta blocker, being preventing arrhythmias. So that was better, and there was 46% relative risk reduction between bisoprolol first. So if we have a patient who cannot be given ARNI or in ACE inhibitor, definitely CBS3 is an indication that we can start bisoprolol first as per this particular one. And even in the Japanese experience also, they said that yes, because beta blockers have definitely an edge, and then they reduce the heart rate, bisoprolol versus, even in comparison to the other beta blockers also, the reduction in the heart rate and reduction, so it would reflect into arrhythmias will be better. The downside of beta blocker is always thought about that patients with asthma and COPD and then sexual dysfunction, etc., would be a contraindication, and then would be this thing where beta blockers are generally not indicated or contraindicated. But this is Cruikshank, and then this is another paper also, this asthmatic people. Asthmatic or reactive airway disease, and then you will see that placebo, bisoprolol, and even 100 milligram atenolol and 20 milligram bisoprolol was compared. And then the airway resistance, AWR, airway resistance, that was not significantly differed even with 20 milligram bisoprolol. As opposed to that, airway resistance increased significantly, producing bronchospasm and worsening of functions with atenolol. And that was about asthmatic. And even the non-asthmatic but COPD patient, there also you will find that bisoprolol 20 milligram, atenolol 100, it was studied. So in comparison to placebo, there was, both the drugs did produce heart rate reduction, but when airway resistance is concerned, bisoprolol was neutral even up to 20 milligram, and opposed to that, atenolol was increasing the airway resistance and asthma. So that is one good point to be highlighted. Especially, I know that whenever my patient goes to Dr. Rupavate, who is a chest physician, very prominent chest physician from my Fortis hospital, the first thing he removes my beta blocker. He says that this is bad. But then if it is bisoprolol, at least this slide shows that yes, you can give even in asthmatic or as well as COPD non-reactive this thing, the COPD patients also. So this is again another slide showing that in terms of getting benefit with NT-proBNP reduction, and then the restoration of sinus rhythm in people with atrial fibrillation and this thing, heart failure, then this is an age. And then that's why this MedCamp did a meta-analysis with 26 studies, 14 RCTs and 12 observational studies, and they came out with this conclusion that bisoprolol has high level of evidence. Then carvedilol, metoprolol, succinate, not the tartarate, have moderate, and tartarate has the least evidence, which was actually in MDC trial but not in MERIT-HF trial. Now another thing is to initiate the treatment, when to initiate, when to give, how quickly to give. Can we give stepwise, just like in hypertension we had step care program, should we gradually go on increasing the drugs? And that's why this second thought came into picture, that earlier you start the treatment, better it is. Because earlier the treatment strategy was to start with one drug, to go for higher dose, see how it is tolerated, then add the next drug, then the third drug, then the fourth, like a stepped care program. But then if you see this, all these landmark trials, the benefit starts within just 4 weeks, 30 days, and then even much earlier, whichever drug, whether it is ARNI, SGLT2, or beta blocker, the benefit starts in the first 1 month itself. So that's why this was a very ambitious, very nice trial, what is called a strong HF trial, which was presented in 2022, which came in 2022 Lancet, and Alex Mebedza, he presented this in 2022 at Barcelona, and ESC Barcelona. And then he showed that this trial also had to be terminated early, because starting all the drugs together and then making them full near target dose within 4 weeks, that had such a great impact that there was in 180 days, there was this thing, risk difference of almost 9% absolute risk reduction of the various event rate. So that was really a good trial which came in 2022 to convince us that yes, we can start immediately all the drugs. And then instead of going, that's why going from this conventional sequencing and taking months together, start all the 4 drugs together and then achieve this benefit which was seen in strong HF trial. So obviously this ACE inhibitor should be replaced by ARNI. So our patient he is on losartan, so that ARBs will be replaced by ARNI. And then these drugs he was not on. He was on some diuretic. So if there is no aldosterone, spironolactone there from rural practice, they may not be using eplerenone. So I think all the 4 drugs in our today's patient we should start in. And then this is very important slide, that what dose we should start with and how to escalate. Generally, when it comes to beta blockers, we should escalate gradually every 2 weekly, and then with bisoprolol, we should start with less dose, and gradually 10 milligram is internationally approved, but then we should go for 5 milligram in an Indian practice. And then these are the other drugs, how we should escalate. Only one thing I would say, that while adding beta blockers, sometimes patient may go into a little bit aggravation of failure, but at that time you can either escalate the diuretic therapy or you can add simultaneously SGLT2. SGLT2 has some diuretic property also. And then these 3 drugs, as I told you, between all these medicines, between Zamatrol, Buxenderol, Nebivolol, and only these 3 drugs are approved. And as you can see here, the guidelines, ACC/AHA guidelines also emphasize that these drugs should be used as class 1 indication, not only in failure, but even to prevent failure with people having less than 40 ejection fraction post-MI or this. So that is like stage B heart failure, who are not in actual failure. So that was the terminal, I think this recommendation in ACC/AHA 2022. And even in mid-range ejection fraction, I said preserved ejection fraction, beta blocker are not so much favored, but even in mid-range, especially when the ejection fraction is little towards the lower range, it can be given. So, and then I think my time is up, so the rest of the slides is just not about beta blockers, but the 5th pillar, like vericiguat should come. Then this, if the heart rate is more than 77 or 80 despite all the drugs, then as the previous slide shows, our ivabradine should come as per the SHIFT trial, because that also had 18% risk reduction, 26% this thing, hospitalization reduction. Iron, if there is, if the transferrin saturation is less than 20%, and then of course this cardiac transplantation, etc. These are little devices which I think last year only it was shown that this device to produce ASD failed. It was thought that with reduced ejection, with preserved as well as reduced ejection fraction, there is a pulmonary congestion and people come with for hospitalization. So if you create an ASD and put a device here, patient will be benefited, but that failed because I think more shunting, more pulmonary hypertension, that did not work. This is still a device which is used many a times. You implant very small device with just 2 millimeter thickness. It goes into the pulmonary artery, sits here, and this is for hemodynamic monitoring, not available in India. And then of course the mitra clip, just because we always say that MR begets MR, more MR, functional MR that dilates the LV, that increases more dilatation of LV. So just put a clip here, reduce the regurgitant orifice of the mitral wall, and then you will get the benefit. So COAP trial showed good result, but then this mitra AR did not show. And then I think this is the last HeartMate, which we are not doing very often. But destination LVAD is still practiced in Western world, and people remain alive even for 1.5 years with that. But what is in our hand is to use all this, our digital techniques and these different technologies to guide us, store the data, electronic medical records, and then get the alerts, and then use this, optimize the treatment with all the 4 drugs. Thank you very much indeed. I think what has been decided, Dr. Mehta, that we will have the question answer in the panel disc, because there is anyway going to be a panel disc. Is that okay? Yeah, okay. Thank you.
Thank you, sir, for that excellent presentation. Our next talk is on coronary artery calcium score in clinical practice. And we invite Dr. Mahesh Shah, sir, to enlighten us further on the same.
All right. Can we have my slide set, please? Well, friends, of late I have seen, there is a lot of awareness about cardiac events. Particularly, COVID has made that awareness more acute. People used to have acute coronary syndromes. People used to have heart attacks in gym, in office, at home, while dancing in a marriage party, and we have a number of videos circulating on WhatsApp. But people were not much aware about before COVID. After COVID, the COVID and COVID vaccines were blamed for increased number of heart attacks. Now every alternate patient who comes to me for risk evaluation, whether he is going to die with heart attack or not, he comes and tells me after COVID, heart attack rate has gone up. I don't think that has really gone up. But the good thing about it is that people are aware about it, risk of heart attacks. So normally we have kind of risk calculators available. In older era, we used to calculate the risk by how many risk factors patient has: hypertension, diabetes, smoking, alcohol. If he has 2 or 3 risk factors, we know that he is falling in high risk group, and he needs to do more of diet, exercise, etc. And in some of the patients, we'll say now, okay, you take statin. So we were very vague about it. There were no precise boundaries cut off. Then came the risk calculators. We had ASCVD risk calculator, we have score calculators, and we have now the latest one is a prevent risk calculator. In those risk calculators, you put certain data: patient gender, age, what is his cholesterol level, what is his blood pressure level, whether he is smoking, alcohol, diabetes, etc. And it gives you the risk that over next 10 years, your risk of having heart attack, stroke, bypass surgery, angioplasty, sudden cardiac death is this much. And then those risk scores are categorized into low risk, borderline risk, intermediate risk, and high risk. So these are the 4 categories they are giving. If you are falling in high risk, you need to be very aggressive about prevention. You need to give them statins, most probably high intensity statin, with your stricter LDL targets. LDL targets are going down and down over the years. And if you are falling in low risk group, probably you don't need anything more than general lifestyle, which is recommended for every normal person in the population. But unfortunately, large number of people will fall into the borderline and intermediate group, which is a kind of a gray zone. And we really don't know whether this group of patients are going to be helped by statins, whether they will be helped by moderate intensity or high intensity. Should we be giving them aspirin? Because once upon a time it was said that aspirin a day keeps a heart attack away. So all those decisions we need to make. Today we are going to discuss about an important test, that is coronary artery calcium scoring, and what is its role in primary prevention. We all very clearly know that so far as secondary prevention is concerned, it's already falling into a very high group, and your LDL targets are dropping from 70 to 55 to 40 to 30 to even 15 in Lipid Association of India guidelines, extreme risk category C. So we are not talking about secondary prevention, we are talking about primary prevention. Even in primary prevention, what coronary calcium score has to play a role is in borderline and intermediate risk group. That is where the maximum confusion is there, and that is where we need the answer. So how do we do the voting, Gargi? All right, friends. So please vote. Do you do coronary calcium scoring in clinical practice? No. Yes, occasionally. Yes, regularly. This is just to know the overall perception. All right. That is what exactly I was doing couple of years back. Let's see whether this changes towards the end of this lecture. Now, there are three cases which I have put up. You just tell me whether you will be doing coronary calcium scoring in this particular patient, whether it will be helpful or not. Same questions will be there at the end of the lecture, and we'll see how much impact the lecture has made. Please feel free to vote, because we are not going to know what is your answer. And many times in medicine, we don't know whether what is right answer today, what is right today may be wrong tomorrow. So this is a 76-year-old male, does not have diabetes, blood pressure is 130, 80 on treatment, well controlled, LDL is 155, HDL 35, triglyceride 185. He is worried about heart attack and he has reservations about statin. Will you do calcium scoring in this patient? Yes or no? All right, great. So 76-year-old, large number of people say that it should be done. This is a second case, again it's a yes or no. 58-year-old man, angina on exertion, NYHA class 2 for last 6 months. LDL 140, ECG normal, echo normal, carotid femoral artery are showing some minor plaques. Whether you will be doing calcium scoring in this patient or not, to convince him to take statins, to take aspirin, etc. All right, great. Not unexpected. And this is the last case. Then we'll be talking about the real science. 53-year-old post-menopausal asymptomatic woman, family history of coronary artery disease, hypertension, on treatment which is controlled, LDL 149, HDL 38, triglyceride 190, ECG echo stress test normal. Worried about coronary artery disease, whether to take statins or not. Will you do calcium scaring in this patient, yes or no? All right. So everybody is in favor of coronary calcium scoring just because it's a topic over here for today. See, risk stratification, this is the prevent risk calculator, which is one of the latest. It's different from ASCVD and pooled cohort equation, which we used to use. It's different because the ASCVD risk calculator used to start from the age of 40. My problem was in India, we start getting heart attack much younger, 10 years younger. This one has taken into account from the age of 30. So from the age of 30, you can do risk scoring and risk calculations. This is the link which is there. In case all of you who have taken pictures, and if you don't find a good picture, feel free to email me or WhatsApp me on this, and I will be happy to share the whole presentation with you. The presentation has nothing proprietary of mine. It is all done with Control-C, Control-V technology, that is cut and paste from internet. Of course, the flow is mine and the jokes are all mine. So with the prevent, as compared to SCOD risk calculator, we had less than 5%, 10-year risk was low risk, 5 to 7.5 borderline, 7.5 to I think 20 was intermediate, and more than 20 was high risk. With prevent risk calculator, less than 3 is normal, 3 to 5 is borderline, 5 to 7.5 is intermediate, and more than 7.5 is high risk. A large number of people are falling into borderline and intermediate risk. That's a problem. Low risk, no problems. Go home, enjoy life. Go to Juhu beach and have pani puri and bhajia. High risk, aggressive lifestyle modification, high risk, high intensity statin therapy, and antiplatelet depending upon clinical judgment. It is the gray zone which is the problem, and there are a lot of shades of gray in that. Why we have a problem? Because there are many risk modifiers. We know that inflammation is a major pillar of atherosclerotic pathophysiology, and that is not accounted for in these calculators. Lipoprotein little a genetically determined lipid, which is both lipid risk as well as thrombotic risk, because it has a structural similarity with prothrombin. Premature ASCVD in the family, the genetic risk, polygenic risk scores are available, but they have not lived up to the expectation. They are not being used routinely. Sleep apnea increases the risk, pollution increases the risk, erectile dysfunction, if you have, there is a higher risk. And on top of that, even among the lipid parameters, we know that LDL is a poor marker. Better marker is non-HDL because it takes care of all atherogenic particles. ApoB is still better. LDL particle size and number might have some hidden better information to risk stratify people. So what do we go by? Risk calculators plus risk modifiers. How do we do it? The proof of pudding is in eating. So if the person has already started developing some kind of atherosclerotic manifestation, no matter which risk factor, he is falling into the high risk category. And here, let us understand why this calcification forms. A lot of our patients ask us, sir, calcification आया है तो calcium लेना है कि नहीं लेना है, बंद करूँ क्या? It's different. This is calcification occurs in advanced atherosclerotic lesions, and it's found in 90% of the men and 70% of women above the age of 70. So you have to look at the what is the probability of them having calcification. And below the age of 30, probably you will not find calcification even in 2 or 3% of patients. And this kind of dystrophic calcification, which is as a result of inflammation, is also found in places where there is a repeated injury and healing, like in joints, tendons, pericardium, breast, pancreas, valves, etc. Calcification occurs because there is a failed or incomplete repair. Normally, when we are cut in the skin, it heals and we don't have a large fibrosis. But if we had a large burn, the burn will get covered with fibrotic tissue. It looks ghastly, and sometimes it might get calcified over the years. So this calcification is largely because of the failed incomplete repair to repetitive or serious large volume injury. That is what we have to remember. So early plaques might be soft plaques and you may not have anything. How is the calcium scoring done? It's a non-contrast ECG gated CT scan, measures coronary calcium burden by angstrom units, which is the area of calcification and density. This is done by machines. Radiologist doesn't have to do it much, and it has got a very low radiation exposure, so it is safe in case if you need to repeat every few years. It is safe. And higher coronary artery calcium scores correlates independent of all the risk factors, with the increased risk of myocardial infarction, stroke, cardiovascular death in future. That is independent because this is the final common pathway. This is the final effect of all risk factors, risk modifiers, and everything combined together. And how do you classify them? 0 is ideal to have, no detectable calcium. You can safely send the patient home if he is asymptomatic. 1 to 100 is mild, 100 to 400 is moderate. It supports statin therapy. Below 100 also, depending upon other risk calculated parameters, you can take a call because already atherosclerotic process is going on. But above 400, you have to have a high intensity statin, and definitely you have to have it. Scores can also be expressed in terms of percentile for particular age and gender, but they are not commonly used. Higher percentile, more than 75 for the age and gender, would probably qualify for a higher risk. And score 0 versus 1 to 100, 100 to 300, more than 300, carries 4 to 7 times. This is 4 to 7 times. We are not talking about 20% increased risk or 50% increased risk. 4 times is 400% increased risk. 7 times is 700% increased risk. So that is the differentiating power of coronary calcium score versus the risk calculators. Per doubling of calcium score, 20% higher 5-year coronary event risk is there. There are many risk calculators available, but all risk calculators, the values can be refined if you use coronary calcium scoring. Power of 0 is very strong. Coronary artery calcium score of 0 reduces 10-year ASCD risk, especially in borderline intermediate. In borderline, it drops the 10-year risk to less than 1.5%. In intermediate, less than 4.5%. Which otherwise the calculator would have told you that, you are falling into 8 or 9 or 10% group. That drops to 4.5. So that's one of the best risk modifier you can see. Where should you be doing coronary artery calcium score? Now here are the answers to all the 3 patients which we have voted so far. It is to be done in asymptomatic adults between the age of 40 to 75 who are falling into borderline or intermediate ASCVD risk group. That is the classical indication. It is not for low risk young people, because by the age of 30, 35, there is not enough of time for repeated injury and calcification to occur. It is not for people who already have ASCVD. They are already falling into high risk. You are not going to differentiate anything further. It's not for people who already need statin. Diabetes already needs high intensity statin. You don't do calcium scoring there. Familial hypercholesterolemia, no matter of age, if his LDL is 190 and above, he needs high intensity statin, maybe something more, statin plus, plus, plus. So they need not coronary calcium, do coronary steering. People who had any prior events, you don't need to do it. People who have asymptomatic plaques, if you do a carotid screening, aortic screening, abdominal aortic screening, or a femoral screening, you find there are atherosclerotic plaques. That is an evidence of atherosclerosis enough. Proof of pudding in eating is already there. You don't need any calcification score over here, because symptomatic patients, pre-test probability already is very high. If somebody who has a classical exertional angina, his pre-test probability of having atherosclerosis is more than 95%. No other test is going to reduce it to something like 40 or 50%. What do the guidelines say? They are more or less congruent and consistent. ACCHA both say that it's for the risk refinement in borderline and intermediate risk group. 0, consider withholding statin, repeat in 5 to 10 years, more than 100, consider statin. So the practical clinical tip is start with clinical risk estimate. Use any of the risk calculator which you are familiar with. All of them are available online. Even if you miss the link over here, just look for Prevent Risk Calculator and you will be able to read that website. If uncertain, then only you do a coronary calcium score. Score comes to 0, de-escalate, 1 to 99, individualize, more than 100, treat at high risk. It may help decide aspirin use in individual cases. If you feel that 10-year risk is more than 10%, the aspirin's 10-year bleeding risk is around 10%. So if it is much higher, then probably you might think of using this thing. How do you explain calcium score? Calcium score is not as good as the blocks tell that. If it is 0, there are no detectable calcified plaque, very low near-term risk. They need not be complacent throughout that life that, at the age of 45, I don't have calcium score, so I'm fine for life. No. For higher scores, emphasize the burden of disease rather than the blocked artery. That is what is recommended. Many times it has been seen that after seeing their LDL level of 150, 160 or a equation showing you falling into a borderline or just touching the high risk group, patients are reluctant to take the statins, but once they see calcification, it improves statin acceptance, statin adherence. That has been shown in a few of the papers. So that is another better advantage, because we have many statin deniers, statin people who refuse that no, statins are bad, they should not be taken. It has also been shown to reduce the progression in familial coronary artery disease also. We need to think about some special populations. Diabetes often automatically falls for the statin group. Coronary calcium scoring may refine the intensity, add urgency, or it may improve the patient's adherence, but beyond that, we don't have much of the role in diabetic patients. CKD patients, there are many other mechanisms for calcification, so take calcification with a pinch of salt. Elderly above the 75, as I told you, 80-90% of people will have calcification. It does not add value, and by age criteria itself, they would start falling into higher risk categories. So it does not add materially to clinical decision making. Women often have lower calcium score at the same age and risk, but still power of 0 remains, and do not assume low risk solely because of the age and gender. Calcium score can still be useful in women. What is the future? The pitfalls are, it detects only calcified plaque. In an early age, at the age of 25, 30, 35, somebody has a familial hypercholesterolemia, LDL is say 250, 300. He might be harboring soft plaques and still his calcium score could be 0. So in young patients below the age of 40, it's not recommended. Non-calcified plaques can be missed. Overestimation is there in diffuse calcification, underestimation in very early disease. So this you have to keep it in mind, calcium score 0 does not mean absence of atherosclerosis always. The advanced metrics like calcium score density, lower density would mean higher risk. It may refine the risk. Lesion specific and regional distribution, whether it is in left main area, proximal LAD area, or mid LAD and diagonal area, or RC area, could make difference, but we don't have data. That is the area of future research. AI and automated detection can, standardize things, and spectral CT may add another dimension to what we can understand and interpret from calcium score. So there are a few cases. This is not for voting. 55-year-old man whose ASCVD risk score is 6, so he is falling into borderline zone. Unsure about statin, calcium score is 0. Now we downgrade his risk. It falls to less than 1.5% over 10 years, and we focus on lifestyle, no statin, recheck in 10 years, 5 to 10 years. This is a second case. 60-year-old male, his ASCVD risk score is 12% chance of ASCVD in next 10 years. Calcium score is 250. So from 12%, now he'll fall into a high risk, from intermediate risk group to high risk group, and you would be considering higher intensity of statin, moderate or high intensity statin therapy with some LDL targets. This is a 65-year-old man with a calcium score of more than 1000. He falls into very high risk calcium score group. I would not do his ASCVD risk calculator. I would straightway go ahead with evaluating him further and putting him on a high intensity statin, in addition to, of course, lifestyle. The future direction is we need more randomized trial for coronary calcium scoring guided therapies, and integration with polygenic, the genetic risk score, imaging, biomarkers, and of course artificial intelligence or machine learning. The take-home points are: power of 0 is very strong in appropriate patients, not in very young patient, and not in symptomatic patients. So very young patient, do not rule it out. Symptomatic patient, calcium score 0 does not mean you put an end to evaluation. He needs further evaluation. Follow the guidelines, tailor it to the patient's values, comorbidities, etc. So the contemporary care key principles are: it moves beyond just LDL to non-HDL to ApoB to LDL particle number, etc. It identifies residual cardiovascular risk, which is confounded by many risk modifiers, and all of them can be evaluated by doing a calcium score, because that is the final common pathway, and it matches the intensity of treatment. Now again, I would request you to vote. Same 3 cases are there. 76-year-old man, no diabetes, hypertension, on treatment controlled, dyslipidemia, which is not very impressive, worried about heart attack, whether you will be doing calcium scoring or you will not be doing calcium scoring. This guy, if you put it in ASCVD risk calculation, it will go to something around 15-20%. He would already be in statin. Vote now, please. Yes or no? Made some dent. Previously it was yes or more, now it is no and more. So lecture was effective. Same case, 58-year-old man, angina on exertion, symptomatic, 6 months, dyslipidemia, classic, nothing else. He already has plaques. Coronary calcium score, will you do or will you not do? I think we are making a dent, we are making a good difference, because this guy already needs high intensity statin therapy and he has angina. He needs further evaluation in terms of functional testing, or if he goes to a cardiologist, straight away go for a cath. Now third case, 53-year-old post-menopausal asymptomatic woman, family history of coronary artery disease, hypertension controlled, dyslipidemia is standard, ECG echo stress test is normal. Should we do calcium scoring, yes or no? Thanks. So these were the key takeaways, and I hope this was worth your time. I hope there will be some carry-home messages and you will be better utilizing this facility. Thank you very much.
Thank you, sir, for that engaging session on CAC. Our next talk would be on hypertension management in diabetic kidney disease, DKD. And we have Dr. Ashok Kirplani, sir, as our esteemed speaker. We invite sir for the talk.
Sorry. Good evening, everyone. Nice to have you on Saturday evening. And thank you, MacLeods, for arranging this talk. My pleasure to be with seniors, colleagues, and young friends. So the first two lectures were so focused that I envy them. I have to speak on a broad subject. I don't know how I'll do it in 25 minutes, but I'll try and do my best. So each hypertensive patient is unique, and some may have just obesity, only diabetes, only tachycardia, and various spectrum of patients that we see in practice of hypertension. Now, the CKD Registry of India established that diabetic kidney disease, or diabetic nephropathy as they called it at that time, is about 27% of all CKD when it did the survey over a period of 2 years. And the second important cause was hypertension. Of course, there were all the others, polycystic, chronic glomerulonephritis, tubulointerstitial disease, etc. But between the two of these, the almost 42% of CKD was due to either hypertension or diabetes, or both. Difficult to say because they come together. But within the diabetes analysis, only 82% were really diabetic nephropathy. Diabetes are prone to other renal diseases also. So, and hypertension is part of those diseases also. So an important point to remember is when you see a diabetic and hypertensive, you need not have only diabetic nephropathy. What in your textbook of pathology was Kimmelstein-Wilson nodular sclerosis. This is an important point to remember when you are treating the patient. But hypertension is the second cause on its own for CKD. Of course, it's a mixed bag, but it is diluted by the volume. When you have large number of patients, you get a correct idea even though it's a mixed bag. This is where it all starts. Unfortunately, when I was young, I have photos of myself looking like this. I don't blame my patient. They love me so much. But this is where it starts. So the remarks I will make today is for T2DM, not T1 at all. So we are not talking about T1. And this is what I'm very fond of, and I'm sure all of you are. But really, this is what caramel is cardiac, renal, adipose, metabolic, eye and liver. We forget some of these when treating the patient. So it's very important when the patient is in front of you, treat these and look for target organ damage, both of diabetes and hypertension if they are coexisting, or of each of them, and see that you don't miss these even as you are looking only at hypertension or only at blood glucose. And this is a global prevalence shows that 80 to 85% of CKD patients have hypertension. Advanced CKD, 95% have hypertension. And hypertension on its own is also globally shown to be the second most cause of CKD, other than diabetes, second to diabetes. Important to remember that there are CKDs who don't have hypertension, and they are the ones who have lived the longest. And from that, research goes not only from bench to bedside, but from bedside to bench. And that is what is the starting point, that a non-hypertensive diabetic will live much longer. And a non-hypertensive CKD who is non-diabetic will live even much longer. And there's so many non-hypertensive, and they have taught us, like polycystic, live very long. Interstitial nephritis, if you give somebody any of these bad drugs, in the olden days we had the ibugesic and all the ibuprofen, NSAID nephropathy. Even paracetamol can cause. In Australia, there was paracetamol causing in large doses, puddies of paracetamol. So those diseases, you stop the drug, the disease stops progressing. That's the beauty of it. And therefore comes the corollary that if you control hypertension, then CKD will become much slower, if not disappear. We know today what is new is that the presence of protein in the urine is very important. And this is where hypertension gets mixed up with treatment of hypertension and proteinuria. So this is the theme, that more the protein in the urine, more is the death rate and the progression to death. And so in the end, when there is macroalbuminuria, there will be every year about 5% of the patients will die. And the macroalbuminuria is what you get on the dipstick. Before that, we didn't know. And so we ignored it when we didn't find it on the dipstick. Today, it's different. The important thing is to convince yourself that sclerosis, that KW, can be reversed. By the time the patient comes to me, it's too late. But when he comes to you as physician, treating physician, pediatrician, young boy, you can reverse this beautiful looking normal glomerulus which has become affected like this in the very early stages with sclerosis. You can reverse it. Dr. Abuna was a transplant surgeon in Kuwait. And in those days, in the very early stages, people did not take diabetic kidneys from cadavers for transplantation. He received a cadaver of a diabetic patient and decided to transplant into 2 people. And at the time of doing that, he took biopsy from the kidneys. And he had, at that time, already some sclerosis, but he went ahead with the transplant. Unfortunately, one of the patients, a few years later, died with kidney function. And he took the autopsy of that. And the autopsy showed that what looked like this was looking like this. That is, putting the kidney into a non-hyperglycemic internal milieu, reduced the sclerosis. This is a proof. Today, if you take a mouse and inject it with a kidney poison like streptozotocin, make it diabetic. After 12 days, sacrifice it, biopsy one kidney, put it into another mouse which is not diabetic, and then sacrifice it. You'll see this same reversal takes place. So this is proof in your mind that it can be done. Once you are convinced, then you will convince your patient that it can be done. Of course, I will come to this later, but spurious microalbuminuria can bug your life quite a bit. So don't rush when you are looking at bad things within what is happening to the patient. Spurious microalbuminuria can be there and you can fall for it. So even at the very beginning of so-called beginning of diabetes, you will find proteinuria. You can have it due to urinary infection, uncontrolled blood pressure, uncontrolled blood glucose, fever, convulsion, very strenuous exercise. Recently I had a young boy who went with his father for health checkup, whole family went, and the boy had proteinuria. And the USCR was some 400 or something. And then I couldn't find anything wrong with the boy. And then I said, let's do it again. And we did it again and it was normal. So I asked him, what did you do? He said, previous day I was on the treadmill for 2 hours. And then the proteinuria came. So this is very important. Don't rush into the diagnosis. If you are looking for the disease in its early stage, don't rush, do it again. That Dr. Chadha will tell you how frequently he does it and what you should do. There's a lady, 61-year-old, went for executive health checkup. And that was in 2016. Her creatinine showed 1.2. And urine examination was a trace protein, WBC 5 to 7, which is normal in women. And rest was NAD, ECG normal, fasting sugar 110, post-lunch 150. Nothing else except reduce weight and salt intake was advised. BP was 140 by 90. In those days, BP of 140 was 90 was acceptable. Yes, reduce weight because she had 68 kilos at 5'2", but that is the correct advice. That's what most people would have done. Today, this would not be acceptable. Later she comes, after 10 years to me. At that time she is 71. Her weight is now 75. She's actually lost 1 centimeter in height, sorry. Blood pressure is now 155. Creatinine is 1.5. EGFR is 37. And she has lost 15 milliliters of EGFR in those 10 years. Sugar is 130 fasting, post-lunch 200. She's frankly diabetic. HbA1c is 7.9, sorry. Urine specific gravity is 1020, but protein is 2+. That's very important that in the olden days it was excusable to say specific gravity not shown because they used to put a urinometer, you needed so much urine, this, that. Now it's on the stick. So it is criminal to ignore it. If a specific gravity is 1040, then even 3+ may not be significant proteinuria. As against that, the specific gravity is 1010, then in trace also is important. So now, of course, over a period of time, you will all get used to USCR. But till then, it's expensive. Doing the albumin test needs special technique. But your stick is so simple. Don't ignore those findings. So you do the USCR, and she has 10 to 15 pus cells. Don't ignore that also. Do it when the pus cells are less and you have looked into the getting rid of that. And she is taking already glycomet. So prognosis in diabetic kidney disease depends on the cause of the CKD. As I told you, 20% may not be due to diabetic nephropathy. Stones are common. Glomerulonephritis is common. People have hereditary disease, polycystic, other things. So it is possible that's another disease. Diabetic status, HbA1c is important, but very important is blood pressure and albuminuria. These are the two things I'm going to talk about. Important to remember what is the baseline EGFR. You must now have a QXMD in your pocket, in your phone, which tells you what is the EGFR. You just have to go online, it's free. Just you have to say, I'm a doctor and give you a degree, that's all. Anybody can get it, even homeopath or Ayurveda is allowed to access it. That gives you the current status because serum creatinine is a fallacious, even though it's very useful, we can't live without it. We have to modify it for age, sex, weight, etc. and then get it right. And comorbidities will exist, stones, recurrent UTI, uric acid. These affect the prognosis of the disease. Now this is, the important problem is that we must get the patient at the primary stage of prevention. That is before the disease strikes, before the proteinuria comes. And that's at your hand, not at mine. I will get it only after disease is established, from stage 1 to stage 5. Now in the past, we only used this formula, the EGFR, and said this is the stage. Today we realize that this is not anything that I can change in a big way. What I can change is the proteinuria. And the A1, A2, A3 is 30 to 0 to 30, 30 to 300, and 300 to more than 300. And this is a heat map which would tell you, once you put your patient in this group, where is he and where would you like to bring him? Obviously, you would like to bring him to green, but you want to bring him, even if you can't bring him to green, bring him up. That is secondary prevention. So the management of high blood pressure in diabetics and in CKD, the remarks are the same. But of course, CKD with diabetes is a double whammy. It's two diseases, so it's much faster. So you get, these are the things that I will have to come look at. The vascular stiffness from atherosclerosis, the volume overload because I can't get rid of sodium, the sodium retention from all the heart failure, the inability to excrete salt, inability to adjust, dilute or concentrate it in the middle stages, in 3 and 4. In the early stages, it's just reduction in sodium excretion. The RAS overactivation, sympathetic drive, and endothelial dysfunctions. If I know the causes, I treat each one. So you'll see soon that drugs will be there for endothelial dysfunction. The others are easy to remember, but that's coming soon. And the vicious cycle is that in the case of hypertension, hypertension alone causes kidney disease, and the hypertension due to kidney disease worsens kidney. So this is a vicious cycle that will operate. So is it again, hypertension is also a double whammy. It may be primary or secondary to CKD, worsening the CKD. And we have been shown by our friend George Bakris in this study that a patient with 140/90 will have a mean arterial pressure of 108, and he will be somewhere at the end of this graph. And that will give me a rate of decline of GFR at 8 milliliters per year. On the other hand, if I am able to succeed to go from 140/90 to 120/70, his rate of decline will go from 8 to 2. And this is in our hands. More yours than mine. And I am limited by the most severe cases, which don't do well. So it's up to you. So the target of blood pressure control is first lower the blood pressure, is not lower the proteinuria. First target is go to the target given to you by all the guidelines that you read. Second is reduction of proteinuria, very important. Third, reduction of cardiovascular risk. To us, heart is king. I want my patient to live long enough to come to me for transplant. But if I lose him on the way from all the atherosclerosis that goes on, and the heart failure, and the urinary tract infection, and sepsis, etc., then it is no good. I have failed the patient. And that's why it's very important, and I have to retard the progression of renal disease. Now, these are the recommendations of the European Society of Cardiology, the KDIGO, and the American Heart Association, ACC. All of them today say that the first-line drugs should be such that they should reduce microalbumin to the lowest level possible. And the GFR target should be, in these cases, if it is more than 30, use diuretics and CCBs as second line, and first line is RAS inhibitor. KDIGO says the same thing, but says 120. But it says 120 target only if it is tolerated. See the parenthesis. Only it's not easy to accept 120 for the patient many times. He got side effects. And the same with American. In fact, the heart people look at 130, but we have adopted, KDIGO is the nephrology branch. They have adopted the further lower target, not to save the kidney, but to save the heart. And this is the dilemma of the nephrologist. One is which instrument to use, which pressure to use. And the second is, should I go to standard control of 135/85? 140 used to be with mercury. With the ordinary electronic instruments, standard was 135. But now, with tight control, as KDIGO says, It's 120, only systolic, no talk of diastolic. And today when we start protecting, look at the central circle, cardiovascular protection. Even though it's our business, we need to protect the heart. So I'm talking heart protection, and we need three things. 24-hour level should be under 130/80. Circadian rhythm, daytime should be less than 135/85, and BP variability should be less. Just like in glucose control, you don't want swings of sugar, you don't want swings of blood pressure. You don't know what happens when that swing occurs, the plaque may burst. And frequent controlling of pressure, in the olden days we used to do yearly, seasonally, visit to visit. Day by day we started teaching patients to do home blood pressure. Good, very good. But then we came to diurnal. That is the classical ambulatory blood pressure. See what happens at night. And the orthostatic, very important, lying and sitting and standing. Is he getting, chakkar from that? And beat by bit, maybe we'll be looking at beat by bit variability. And this is the gold standard, the ambulatory blood pressure. I need not say more, difficult, but still the gold standard. And these two studies have shown very beautifully, this actually one study is called the Crick study, and it has shown that the prognostical significance of ambulatory blood pressure in CKD is very important. And the most important finding was that masked hypertension and elevated nighttime blood pressure is the biggest headache for the CKD patient. It is a classical ambulatory blood pressure of a CKD patient. You see, this is daytime fine and then some little activity, but come to night and see everything goes haywire. Now, why does it happen? It's very complex. But the most important thing is, if you see your patient of CKD, you'll see all that fluid in the legs. And when he comes to the recumbent position, all that fluid is mobilized towards the heart. And that gives the pressure imbalance within the vascular system. And that's the most important cause. And then you get this early morning rise of pressure when the patient comes to you with breathlessness or angina or heart attack or stroke. Everything happens from 4 a.m. to 7 or 8 a.m. So that's a big problem, and this is much more common in our patients, CKD patients, than in the ordinary essential, bad word, essential, it's not essential, hypertension. And this shows you that if a patient in the red are the patients who are well controlled both at home BP, that means daytime BP, and night BP, then the UACR is significantly reduced. And the NT-proBNP is also significantly reduced. Against that, those only controlled with home BP, means daytime, but no nighttime. You can't do home BP at night. Poor nighttime control, actually the NT-proBNP goes up. So you have a significant answer to why masked hypertension takes precedence in the CKD patients. And if you look at this study, it's about 10,000 patients, but 1,500 patients almost went through ambulatory blood pressure. And if you were to look at them without looking at night pressure, 27% would have been misdiagnosed for masked hypertension. So that was picked up by ambulatory blood pressure. And white coat hypertension, also very common, and sustained hypertension. So 31% benefited by having a nighttime pressure. And these are the targets. It tells you how the things went in by targets. And now we've come to 120. Tight control is important, particularly to save the heart. The dilemma for us is when we do tight control, pressure gets controlled, but creatinine goes up. And when we let go of it, blood pressure gets, goes back up, creatinine comes down. Now, what should the patient be told? You see, this patient was given RAS inhibitors. He went from a proteinuria of more than 300 albumin to a proteinuria of less than 30. But his GFR actually fell. But when it fell, he went from orange to yellow. Now, how should I convince that patient? If I can't convince him, how will you convince him? So this less than 120 millimeter controversy is a big problem for us. And yet, we are ready to bell the cat. Why? We have to explain to the patient that love your heart and brain. Kidneys, I can remove both and throw them away. I have many patients who have no kidney at all, and they are alive and well on earth. I don't have a patient who has no brain or no heart. So the most important thing is convince your patient, and for us it becomes a huge problem. This is the study from the tight control. This is from SPRINT, and SPRINT shows that the serum potassium problem was 2%. That's not a small amount in the patients. That it can be critical or it can be subcritical, but it's a nuisance value. And the more the pharma industry pushes the potassium binders on us, which they are doing right now, the more is the headache for us. Normally 5.7, jaane dena, theek hai, kuch nahi hoga. No, now I have to make sure that I give him something or the other and make sure that the potassium comes. I will take a few minutes more with permission of everyone, okay? So this shows you that even in normal people, the SPRINT study was not for CKD and it had no diabetics. But it showed that CKD progression risk ratio was 1.36. In fact, it increased the chances of CKD. And CKD developments means de novo CKD was 1%. So that, it's not 11% more. And incident albuminuria was the other way around. Albumin came down on control of pressure. So the pharmacology therapy has to be renoprotection after reducing the BP to target. Again, target is important first, then proteinuria, then CVD risk, and then what I told you about it. Now, this is the new classification which I already explained. The important thing is which drug. So we have the same as you have in general medicine. ACE or ARB, first choice, calcium channel blocker, second choice, or diuretic, second choice, one of the two, depending on the clinical situation. And it means that you have to examine the patient. It can't be done by phone. And of course, fourth choice are all these drugs. And why is it so important? Because the renin-angiotensin and aldosterone blockers, but the second A is later, the first A is important. Telmisartan is the best drug. And I'm not pushing it because this company makes it or not. Let me give you the answer why. We know that our Indians don't tolerate the ACE inhibitor. We know that this reduces proteinuria best. It passes the blood-brain barrier. Today we know that one of the major causes of dementia, both Alzheimer and vascular, is due to the RAS system in the brain. And this drug, only 2 drugs cross the blood-brain barrier from the RAS system. None of the ACE inhibitors cross the blood-brain barrier, and only telmisartan and candesartan cross the blood-brain barrier. So in a young 45, 50-year-old diabetic, when you are using ACE inhibitor ARB, and you're going to use it for a long lifetime, you reduce his risk of future dementia, and a huge amount of research going on it, by using either telmisartan or candesartan. None of the others. Some calcium channel blockers are being checked in Japan. We don't know. But this is the sum total of why this is superior even over the CCBs. Now, there are dangers. One is rising creatinine, and the second is hyperkalemia. So not all patients are really on these drugs because of these dangers and because of the withdrawal of these drugs. And the important thing is you must preemptively withdraw RAS blockade when you have volume depleting surgery, like a bypass, or even for angioplasty we now withdraw. On sick days, when you have diarrhea, vomiting, you must withdraw. You must tell the patient that please withdraw, don't. Otherwise, my own brother-in-law got into AKI because he didn't withdraw his telmisartan when he got severe diarrhea. So gastroenteritis, acute shock, you will get acute rise of AKI because of this. So these precautions have to be. Now, for non-RAS blockade, we have the calcium channel blockades, DHP, including cilnidipine, I'll come to this in a minute, amlodipine, diuretics, Of the diuretics, you classify. You want to do only for hypertension, then thiazide and thiazide-like. Thiazide is hydrochlorothiazide. Thiazide-like are indapamide, chlorthalidone, which is probably the best up to GFR of 25, or indapamide or metolazone. These are the thiazide-like. And these are useful in these indications are clearly given here. And beta blockers, the two types again, vasodilator and non-vasodilator. Now, beta blockers, when I used to use beta blocker before, all the cardiologists will laugh at me. Haven't you read about some study called CAFE study? And this is, useless because it doesn't reduce central aortic pressure. But the vasodilatory ones, like bisoprolol, you had a beautiful lecture just now about bisoprolol and carvedilol, they all have their indications. All written here. You're welcome to take this whole presentation and read it again. And then the direct vasodilators in resistant hypertension, minoxidil, hydralazine in pregnancy, alpha-dopa, and I think I missed the alpha blockers. Yeah, alpha blockers here. Because of prostate and outlet disease, this is the choice of drugs. And there are two classical CCBs, the dihydropyridines such as nifedipine and amlodipine, and non-dihydropyridine like diltiazem and verapamil. These two work on the heart adversely. Their adverse effect on heart failure, so not very good. They are bradycardic, so you can't use them together with atenolol and all these. These non-dihydropyridine. As against that, major drawback of amlodipine is edema, tachycardia, reflex tachycardia, renal non-protection. In fact, it increases proteinuria and no effect on proteinuria. So even same with nifedipine. This is the real-world data shown once on cilnidipine. And cilnidipine is different, and I'll show you why. But it shows this data of proteinuria is in conjunction with RAS inhibitor, not alone. No drug beats RAS inhibitor for reducing proteinuria, but it works on proteinuria. If you don't get a 1 + 1 is 2, you get a 1 + 1 is 4 when you do that. This reduction of pressure is good, but not as good as amlodipine. On a bad day, I would use amlodipine. If it comes with 200 by 120 first, I'll give amlodipine. All these are mild, but they're useful. They're adjuncts. And why are they adjuncts? Because this is where all the business of hypertension in the kidney and proteinuria works. The whole idea is to reduce the intraglomerular pressure. Now, systemic pressure is transmitted to the glomerulus, but when you give an L-type blocking calcium channel blocker like amlodipine, which is only on the afferent arteriole, it dilates the afferent arteriole and actually increases the glomerular pressure and increases the proteinuria. That's why amlodipine on long run is not good for proteinuria. On the other hand, the cilnidipine works on the other side and this side. So it opens both afferent and efferent, because on that side there is the N-type which is on both, and because of that it opens up. I won't go into depth. And of course the RAS blocker works there with the efferent by reducing the tone of the efferent and allowing the blood pressure in the glomerulus to come down. Now, diuretics is the last part. Again, diuretics I either give to dilate the vessel, that is the sodium content of the vessel, which is useful with these thiazide and non-thiazide type and like. And the best is chlorthalidone, except that it's difficult to get. The loop diuretics are used when the patient is in late heart failure. And there, because the patient, when you use them, you need higher doses like furosemide, torsemide, but that is for volume. So volume depletion is best with loop diuretics. Arterial tone is best, arteriolar tone is best with indapamide and these chlorthalidone. Potassium channel, triamterene, it's gone now, it used to be there, very good. MRAs. Now MRAs, we thought that MRAs only work on the tubule, but now there are MR receptors all over the body, in the brain, everywhere. So the MRAs are coming up well, and you will see sooner or later new MRAs. I'll skip these, except to tell you that patient asks me many times, what should I drink? How much water should I drink? Now, these are diuretics, but in the end stage, the patient loses the ability to concentrate and dilute the urine. He drinks too much, he can't dilute. So you have to tell him how much fluid can he drink. And normally, to a normal person, the more fluid you drink, the more urine he will pass. But in the kidney patient, in renal failure, he is only allowed to drink as much as urine as he passes. And that's difficult. I can't tell him to measure his urine every day. But what I can tell him is to buy this. A weighing scale tells me, and I tell all my patients, I see them and tell them, this is your dry weight. On the day you are more than this, take a diuretic. And on the day you don't have that much weight, don't take the diuretic. And then next day do the same thing. Otherwise, many of the patients will end up in hyponatremia. And that in end stage can be a disaster. I've skipped some slides for want of time. And final slide, principles of antihypertensive therapy. Single hypertensive, not representative of the true BP in a CKD patient. Do either ABPM or surrogate of ABPM. We do in our office the sprint method, 3 unobserved method, three readings at 2-minute intervals each, and average of that, after the patient has sat down for 10 minutes. Then we do the pressure, which is a surrogate. It's not a perfect thing, but I can't do ABPM in a minute. Define the target and different targets for different diseases. Remember, every disease doesn't need the same. Like polycystic doesn't need 130 or 120, 130, 140 is fine. Non-proteinuric also doesn't need such a low target. Average requirement is 2.5 medicines. So CKD, some drugs preferred over others. Discuss possible side effects with patients, especially about this creatinine going up and potassium going up. RAS inhibitors, first choice in proteinuric CKD, and ARBs better than ACE inhibitors, with all due respect to my cardiac colleagues who think that ACE inhibitors are better. And after starting treatment, monitor frequently at the beginning for efficacy and side effects. If you don't monitor, you come out with a black face. Escalate doses only after 4-week intervals. There is a large potential for using new N-terminal CCBs. CCBs reduce proteinuria only when they are used with RAS blockers, most. They can reduce otherwise also. And if lack of response, look for non-adherence, patient being on hypertensive medicines like NSAIDs, nose drops, etc. OSA, obstructive sleep apnea, very common in CKD. Do ABPM, manage as a resistant hypertension. Today, new drugs are coming. I have no time for this. However, you will see a Saxaron, Baxdrostat, maybe next week if you are attending one of my lectures, I will be speaking on those. And last slide. Contrary to what Rajiv told you, in cardiac failure, go all in. In renal CKD, don't go all in. You might fall flat on your face. Potassium and creatinine rising. Potassium kills the patient, and rising creatinine kills the nephrologist's reputation. Thank you.
Upon Mr. Varju. And we also have Dr. Ketan Mehta, sir, with us. Sir, to felicitate, sir, I call upon Mr. Manoj Jain ji. Come. Thank you, sir. Now, next session on endocrine hypertension, and we have Dr. Manoj Chidda, sir.
Okay. So I'm standing between you and your cocktail dinner, so we'll do it faster. No, the reason I asked Mahesh to stay on is sitting here for the last 2 hours, for nearly 2 hours, has been a learning experience for me. I don't need to talk about Dr. Kriplani. He's been teaching me for the last 30 years now. And he's getting better day by day, like excellent wine. I won't call him old wine. Dr. Karnik has been my teacher from MD days. And today I learned a lot about the calcium artery scoring. You know, the controversies, because I'm not a great fan. I didn't raise my hand, but I'm not a great fan of calcium scoring. And you told me that when it's already known, there's no idea documenting that the calcium score is high. Thank you. So what I'm going to do in the next 20 odd minutes is take you through another cause of hypertension. So, you know, we use the word primary hypertension, essential hypertension, but all hypertension is not without a cause. And as time is passing on, we are realizing that probably we are missing out a treatable cause of hypertension. And that's what I want you all to carry home with you today. So I'm going to quickly look at the incidence and causes and when should we suspect endocrine hypertension. I'm not going to be discussing diabetic hypertension, which you've heard very well, and I'm not going to talk about obesity hypertension because that you need another 2 hours then. So we'll talk of common endocrine disorders. So this slide says it's about 5%, but if you have heard William Young, the grand old man of adrenal hypertension, he'll tell you that 10% of so-called essential hypertension is primary hyperaldosteronism. So we have to start thinking about now endocrine hypertension in a large majority of your hypertensive patients. I don't have an endocrine lab, so I'm not trying to promote it from that angle. So if you were to, look at the common causes, I think at the top is the adrenal gland. And one thing that has happened with rampant CT scans, not necessarily only the abdomen, but even the chest, because after COVID, when they were doing CT scans of chest, they started, the lower cuts went down to the adrenal, so they started picking up adrenal tumors, adrenal incidentalomas as they were called, because otherwise the patient was asymptomatic. And then one thing led to another, routine investigations, and we started picking up adrenal hypertension there. So that's primary hyperaldosteronism. Classically, we were taught, about the triad of hypokalemia, hypertension, alkalosis. But let me tell you that you could have primary hyperaldosteronism with one of these or none of these. So you have to, look at doing some specific investigations that I'll talk to you as a screening tool. The next group, not so common, but in India, Cushing syndrome is not because of an internal disease or an endogenous cortisol production. For us, it's iatrogenic Cushing's, somnopathies, using steroids for unknowing patients. I won't take names, but the fact is, for me, when I see a patient doing well with asthma, arthritis, dermatitis, unless proved otherwise, he is on steroids or he or she is on steroids. So I would definitely look for a serum cortisol in these patients for iatrogenic Cushing. But Cushing syndrome can present as hypertension. Classically, the weight gain, the central obesity, the buffalo hump, the skin changes, hypertension with hyperglycemia. And 1 or 2 young patients I remember who actually presented to the hospital after tripping, falling, and breaking their bones. And then the physician started looking backwards. So keep that, element of suspicion in your mind when you're seeing these patients. Although having said that, today if you see the polycystic ovarian syndrome or the metabolic endocrine disorders, you will see that everyone of these patients look like Cushing syndrome. So you can't keep investigating all these patients, but keep an element of risk, a suspicion in your mind when you find any of these factors. Pheochromocytoma, again, not common, but not so rare either, if you look for it. And the standard teaching of episodic high blood pressure, diaphoresis, hypertension, headache, may be there in some patient and may give you the clue, but then there are others who may just have subtle changes. They don't have to have sustained hypertension. They may just be getting episodic hypertension, and the classic example of episodic hypertension is when the tumor is in an extra-adrenal place, like say in the urinary bladder, and every time the patient goes to pass urine, he or she may experience the hypertension. Yeah, I'd requested my colleagues at Omnicurus to help me out. So just to sort of tell you that the layers of adrenal cortex from outside to inside, glomerulus, fasciculata, reticularis. So glomerulus with the mineralocorticoids and the fasciculata with the glucocorticoids. And right inside is the medulla, which is connected with the catecholamines. In addition, I think if you look beyond diabetes, then it's the thyroid disorders which are very common, and hyperthyroidism, thyrotoxicosis. We don't want to dissect the two things, but they are actually different. So thyrotoxicosis is the broad term to say that the thyroid hormones are increased, and that's why you have traditionally been taught the tachycardia, palpitations, tremors, excessive sweating, excessive appetite. So think about that. And hyperthyroidism is a specific situation in thyrotoxicosis where the gland is hyperfunctioning. So a Graves' disease, a nodule, a multinodular goiter could all present as hypertension. And as the patient grows older, please remember that there is a condition, extreme condition called apathetic hyperthyroidism. So it might be just hypertension, it may just be arrhythmia, atrial fibrillation unexplained. Think of hyperthyroidism. And here the contrast, the opposite side also in hypothyroidism, because of increased peripheral resistance, the patient may be having diastolic hypertension. So in hyperthyroidism, it's more of a systolic, broad pulse pressure, whereas with hypothyroidism, it's a diastolic with a reduced pulse pressure. Parathyroid, again, traditionally was a disease of stones, bones, groans, and psychic overtones. But now with routine biochemistry showing you a calcium report, we're picking up a lot of asymptomatic hyperparathyroidism. So hyperparathyroidism, hypercalcemia, vascular sensitivity, and hypertension would go in hand, and it's a treatable cause for hypertension. Growth hormone excess, acromegaly, again, these are, I think, self-explanatory, and we don't need to really go into details, but an acromegaly is something you have to pick up on the first sight, because if you keep seeing someone repeatedly, you will never think of acromegaly. And this is specifically true for your old patients, for your family members, you will never be able to diagnose it. It's only when you see them for the first time and you have this thought, it will strike you. And like I said, today we are not going into insulin resistance and obesity and diabetes part. So when do we really suspect these things? First and foremost is young hypertensive. I don't know whether 40 is the right figure, or for us it's 30. But if you see a young hypertensive without a family history, otherwise doing well, not in that obesity category also, please think about it. Resistant hypertension, which normally your experience says that this patient should have been doing well on 1 or 2 drugs, not CKD. Dr. Kriplani told you 2.5 is a normal there. So let's not look at that side. Family history of early cardiovascular or cerebrovascular accident and death. Think about that. Severe or accelerated hypertension, a very short history, and things have started getting worse. The various features that I talked about, endocrine disorders. And one thing, electrolyte disturbances unexplained. So not due to a diuretic, not due to an NSAIDs. So if you see hypokalemia, think about an endocrine problem. So the diagnostic step ladder, I'm again repeating that each and every hypertensive patient, you're not going to rush into this whole set of investigations that I'm going to talk about. But clinically, at least spend 30 seconds to evaluate, if not more than that, that could this be a secondary hypertension? Could this be a treatable? So the important thing is it a treatable thing? As I talked about William Young earlier also, when he says that 10% of patients are primary hyperaldosteronism, it doesn't mean that these are patients with hypokalemia and alkalosis. These are patients who are doing extremely well with your standard of care because our medicines are so strong. But if you could pick up primary hyperaldosteronism, probably you would use a drug specifically for that. So assessment and then going on to lab evaluation and then targeted imaging. I put this slide here so that I want to discourage imaging before you have a clinical and laboratory diagnosis. I used the word incidentaloma a while ago, and I repeated that in endocrinology, if you were to randomly select so-called normal people, 12 to 15% of them will have a pituitary tumor, 10 to 12% of them will have an adrenal tumor, and then it'll be very difficult to separate the actual clinical cases from incidentalomas. And more than that, how do you explain to a person that they have a tumor? Oh, don't worry, this is just an incidental finding. You'll obviously say that this doctor doesn't know what he's talking about. They need to go to some other doctor. So first laboratory evaluation and then targeted imaging. So what laboratory evaluation? I'm giving you just the screening tests. If you see a patient who screens positive, then obviously either you contact your friendly neighborhood endocrinologist or go back to your textbook and just ask 3-4 questions and get your answers. So as I said, top of the list is primary hyperaldosteronism. So clinically, hypokalemia, alkalosis, resistant hypertension. A simple thing is to get a good lab to do a plasma aldosterone concentration. Most people earlier used to do plasma renin activity, but some good labs are now actually giving you an aldosterone concentration. So the ratio of aldosterone to renin activity or aldosterone to actual concentration. Please remember your physiology. When aldosterone goes up, the renin gets suppressed. So if there is a primary hyperaldosteronism, the renin is going to be very suppressed. We look at the ratio of 30, but 30 is actually low. You would have to raise the figure. But forget the ratio. Absolute aldosterone more than 15 and the renin activity is gone below 1. You know that there is something wrong. They need to have more diagnostic tests. Cushing syndrome, I talked about the clinical presentation. A simple thing would be a basal cortisol, an overnight dexamethasone suppression test. For those who are not familiar, 1 milligram of dexamethasone at 11 p.m. and followed by serum cortisol in the morning. It should be less than 2 micrograms per deciliter. It's a very good diagnostic tool. And if you really want to go for a second test, then a 24-hour urinary free cortisol. Anything more than 100 is suspicious. And then we go into the full diagnostic test if something is picked up, whether it's adrenal, whether it's the pituitary, or whether it's an extra-adrenal source. Pheochromocytoma, we had the traditional VMAs and things like that, which should be given up completely. All good labs will give you plasma-free metanephrine and normetanephrine, which are metabolites of the catecholamines. Again, good diagnostic, good screening tool. Please remember, if the upper limit of normal in the lab is 100, that doesn't mean 110 is pheochromocytoma. You need at least near doubling of that normal before you really become suspicious. Unless your clinical suspicion is so high that even with a 10% increase, you want to further work it up. But otherwise, between the normal and the disease state, there is a big gap. Hyperthyroidism, I think everyone is very familiar today. I think TSH, T4, T3 is done part of any routine screening like the CBC and the sugar and BUN and creatinine. Hyperparathyroidism. See, the beauty about endocrinology is that there is a hormone and there's a controlled factor, and then the controlled factor works back on the hormone, the negative feedback. So you see a serum calcium of 10.2 or 10.3, which is the upper limit of normal in that lab. The 10.5 is the upper limit, and 10.3 you're seeing. You would expect the PTH to be low normal. So if this PTH is normal, high normal, then it becomes suspicious. So you need to then further look into other reasons why this is happening. And for our setup, high calcium, low PTH, you know that this is a non-PTH dependent hypercalcemia. That means vitamin D intoxication and sarcoids in granulomatous disorders. high calcium, high PTH or non-suppressed PTH, then we know that this is a parathyroid-induced hypercalcemia. So that way, things become easier to follow it up. But in our setup, with rampant vitamin D deficiency, you will find high or low normal calcium, PTH is very high. You correct the vitamin D deficiency and repeat these tests, you'll find that the calcium has gone high and the PTH still remains high. So that way you can separate the primary hyperparathyroidism with normocalcemia versus secondary hyperparathyroidism with normal calcium. I hope pre-prandial I'm not confusing you at this stage. And the last part in this slide is on acromegaly. I think we've been traditionally taught the clinical features. Acromegaly means the acral parts, the head, the hands, and the feet. We don't wear the hat, so we never talk about the size of the head, but the size of the shoes, chappals keep increasing, and they get spoiled very easily. You know, instead of using it for a year or more, within 3-4 months, they start getting spoiled. And we don't have gloves also to talk about the acral enlargement. But acromegaly, if you see, which is pretty far developed, you can't miss it out. The problem is most of our patients come very late. I wish we could pick them up earlier. Dr. Nagpal, who was our neurosurgery professor at KM, he used to say that his results are so bad because the patients come with a macroadenoma. If we can pick them up early, things would be good. And acromegaly, I think the investigation is very simple. You just do a IGF-1 or a glucose-suppressed growth hormone, and you can get an answer. And then you can go in for the morbidity attached with acromegaly, the heart status, and et cetera, et cetera. I think the last line, if you can't read it from there, let me tell you, it says clinical suspicion drives targeted laboratory investigations, and imaging always comes last. You have to control this desire to, let me get this because it is so easily available in my center. These are the red flags and hypertension emergencies that I've, I think, talked about and you people are familiar with now. The ACC, the AHA, the European Society has all been recommending, the Endocrine Society from the US has been recommending that you must have your threshold for screening for endocrine disorders pretty low. And what I just talked about, the adrenal screening, hyperaldosteronism, pheochromocytoma, Cushing's, the thyroid screening, I don't need to tell you anyway, you keep doing. Look for calcium because that is not as rare as most non-endocrinologists would suspect. Acro maybe is not so common, but you'll think about it. So sort of summarizing the whole talk, think about the endocrine disorder. Once you've got that, start the investigation. But at the same time, you can, I mean, it's not that because Dr. Chadha said first do the diagnosis, I'm not going to treat the hypertension. I think whether it's Dr. Karnik or Dr. Kriplani, everyone has stressed on the fact that the control of hypertension has to go hand in hand. There was a teaching that when you're looking for aldosterone, don't put them on ARBs, don't use this drug, use that drug. Really doesn't matter. When you're screening, just screen on the treatment that the patient is taking. You have a diagnosis, therapy is possible, probably you will prevent a lot of complications, cardiovascular complications that we've been talking about since evening. Yeah, I think we're pretty clear about management, so whether it is surgical management, whether it is medical management, whether it is, I think with pheochromocytoma, probably I just want to stress that pre-op management is much, much more important than the intra-op and the post-op. So in the past, when I say past, I mean 35, 40 years ago when I was a student, we used to hear about patients dying on the table, sudden arrhythmias, sudden hypertension once anesthesia was induced. And now we realize that if we prepare these patients with alpha blockade first, followed by beta blockade. Standard treating is start beta blockade and then think if there is a prostate problem or something. Alpha blockade is not a part of our regular hypertensive treatment. But here, alpha blockade followed by beta blockade. And alpha blockade phenoxybenzamine is not easily available. So we have good data from KEM Hospital, well established, published, that you can use amlodipine in these patients instead of if you don't get phenoxybenzamine. Hyperparathyroidism is fine, thyroid is medical treatment, and acromegaly is the transsphenoidal surgery with a good neurosurgeon doing that surgery. These supportive measures, I think, are going to be there as it is. One thing that I keep talking about is the salt intake in our diet. I'm not saying it should be low salt intake, but I'm saying at least bring it to the normal recommended salt intake of 3 to 5 grams. Most Indians, and especially South Indians, the diet contains 12 to 15 grams of sodium. Salt, so that has to come down. And proper judicious use of antihypertensives. The last 2 or 3 slides to just sort of tell you about the adrenal disorders that I've been talking about. Young female, resistant hypertension, amlodipine with ramipril. During pregnancy, she came for hypertension. Her father had died at a young age. Very high levels of aldosterone, suppressed levels of renin. So forget the ratio. The fact is aldosterone is very high, renin has gone down. So if you have aldosterone very high and renin also very high, then you know you're dealing with a renal problem. But in this situation, it's primary hyperaldosteronism. Get a good surgeon, get the adenoma out. The blood pressure generally reverses to normal, provided it has not changed irreversibly in the vascular tree. Then hypertension may be persistent, but at least it will become easier to treat. They won't need 3 and 4 drugs. Again, 34-year-old male, severe hypertension, tachycardia, shortness of breath. These are very straightforward cases, but like I said, sometimes you have to think about it in a borderline case. So that's my last slide. Screen early, at least think about endocrine hypertension. Clinically, you don't have to do all these investigations in every patient, but you have good, precise laboratory tests to pick up these diagnoses. Once you have the diagnosis, laboratory-wise, clinically, then go for the imaging and treat definitively. Like I said, this is a treatable, reversible cause of hypertension. Thank you for your patient hearing.
Thank you, sir, for that lucid presentation. Now comes the most interesting part of this academic meet. We'll have the expert panel discussion on the CKM syndrome, the cardio-kidney metabolic syndrome, and that would be moderated by Dr. Ketan Mehta, sir. Can we have the setup, please? And we would have our expert panels, Dr. Rajiv Kanik, sir, Dr. Ashok Kriplani, sir, and Dr. Manoj Chadha, sir.
That's okay. That's it. Yeah, 3 only. Yeah, 3. Good evening, everybody, and welcome to this very interesting panel discussion on CKM syndrome. Friends, first let me thank MacLeod's for arranging this program, the academic partner Omnicuris, and of course IMA Mumbai West for the credit points. I can see on Saturday evening the house is all full. It reminds me, we had the renaming of various cities, structures, areas, which started by various political parties. So if you remember, Victoria Terminus became Chhatrapati Shivaji Terminus. And yes, sir, your turn will come, sir. We'll call you. Don't worry. We are just starting, sir. I know you're too impatient for this thing, and our panelists are also really are eagerly awaiting, but give some time, sir. You will get the chance. We had Aurangabad becoming Chhatrapati Sambhaji, and so on and so forth. That was whatever may be the reason behind it. But that didn't stop only over there. In medicine, that is also a common trend. Now, of course, there must be some reason behind it. We had, all of us were talking about NASH, and then we were talking about NAFLD, and suddenly last year we realized, oh, the renaming has happened. Now it has become MASH and MASLD, which we know when we are talking about this entity. Recently, we have learned about PCOS, which was there. They said, now let's rename. It has been an old one, and they came out with a new name, PMOS, which is, you are aware about it. Similarly, we had years back Syndrome X, which was the name given by Revan. In fact, it was also called as Revan syndrome or Syndrome X. And after few years, it got changed. It's not why X. X is a suspense. We know there are so many facts with it. It was labeled as metabolic syndrome. Now, it started having tags to it. We had, from metabolic syndrome, started having cardiometabolic syndrome, which we are talking about. In fact, if you see, it has been labeled as a cardiometabolic syndrome or cardiometabolic summit, where we are discussing about that. And now we have a CKM syndrome which has come. CKM means cardiovascular kidney metabolic syndrome is there. In fact, I was asking MacLeod's, how come you have not put K in between? So they said that, because Kriplani sir is with K, we have Karnik sir with K, and we have Ketan Mehta with K. So K is overpowering, need not to write, and that's how they wrote, it's okay, we write cardiometabolic, but we will discuss CKM syndrome. So we welcome all our panelists for this exclusive panel discussions on CKM. I'm also going to ask questions because Dr. Rajiv Karnik was very keen that we will have questions of each session at the end so that there is no overlap, which we know, which we would be covering. Now, this CKM syndrome, what has happened is so much evolution and changes which has occurred. Let me tell you, exactly 48 hours back, on 9th of July, 2026, for the first time, the 4 major bodies came together. American Heart Association, American College of Cardiology, American Diabetic Association, and American Nephrology Association. They came together and has come out with a position statement for cardiovascular kidney metabolic syndrome. Now, look at the beauty of, I don't know how many of anyone has read this publication which has come in the circulation 48 hours back. Anyone? Okay, good. So if you have not heard, then this will be of very interesting. Now, in that paper which has come in the circulation, what they are focusing is 4 components which they are strongly proposing. And first component is for prevention. Second is detection. Third is evaluation. And fourth is management. So it is starting with prevention, in which we have heard in previous speaker, Kriplani sir was so much talking about, right from beginning talking about the prevention, and which is so utmost important. So same thing has been talked about. It's a 109-page beautiful. Was that the signal to stop early, or we don't know? I think let them tell prevention is better, because first is prevention. So let's be little proactive on it. So this is a 109-page beautiful position paper which has come, and which is of relevance not only for the cardiologist, not only for the nephrologist, not only for the metabolic consultants or endocrinologist, but as a physician at large. So I can see the most of my colleagues who are here, so practicing consulting physicians. So for us, whatever our previous speakers have spoken, and now they have realized that segregation or separation of the department is slowly vanishing. And all of them are now looking into that we don't have to look or specifically focus from one area. We really look into the various segments. So gone are the days where cardiologists would not be interested in looking for other parameters, or the nephrologist would not be looking into the cardiology practice also. So now we will have the questions. Of course, we will allow from the audience also. So I would start with Dr. Koenig, sir. You mentioned about the beta blockers in heart failure and the data which was there about the 3 specific ones. We have now few data coming up, and there is a study of nebivolol in heart failure. So what is your take on that? And so why I am asking, if somebody who is on nebivolol, well settled in terms of for blood pressure point of view, now has got a heart failure, would you like to switch over, or would you continue with the molecule?
Yes, basically the guidelines are based on the evidence-based. And the largest evidence we have for metoprolol, carvedilol, and to some extent bisoprolol. And nebivolol, the seniors trial is there.
Yes.
It's not that there is no data, but the quality evidence and then the number of publications, if you see, so those are generally considered when the guidelines are made. And then that's why we saw that in ACC/AHA 2022 guidelines, it had categorically mentioned that only when it comes to beta blocker, think about only these 3, that metoprolol, carvedilol, and bisoprolol. Not atenolol, not buxindolol, not, in fact, buxindolol, this thing, they had increased mortality rate. Even the ISA activity also had increased mortality rate. Nebivolol had some benefit, but not as much as the rest of the 3. Rest of the 3 drugs had almost 35% relative risk reduction. Nebivolol had 18 to 19% risk reduction.
Okay, so now what you are mentioning is specifically in terms of a heart failure. But now if we have to talk about the CKM, now somebody who has a high risk and on this, where do you put, or would you have a preference of beta blockers talking about the CKM? So somebody who does not have heart failure, you are having putting him in the CKM. Now we have got a staging system which has come up with the CKM also. So would you have the preference depending on the CKM staging, the choice for beta blockers particular?
I would say that the guidelines do not promote so much for the beta blockers in the first place. In as far as this NICE guidelines and then various other Western guidelines go. But American Society of Hypertension, they did propose that beta blockers should come up front, especially the vasodilatory beta blockers. Then subsequently now European guidelines have also said that beta blockers can come up even in stage 1 as the first step in management of hypertension. So if the patient has metabolic syndrome with increased sympathetic drive, which can be very easily seen with tachycardia, or we don't go for muscle sympathetic nerve activity and then this, but then even ambulatory BP monitoring, Holter monitoring, then your device reading, which patient says that my Apple Watch constantly says that you were sitting and your heart rate was more than 100. So those kind of things we are getting now. And then I believe that the UK Biobank is the gold mine, the richest source of this wearable device data. And that will give us very clear-cut idea that how many people have this high adrenergic drive, which especially the Indian community in UK will have, as per our genetic constitution will have. So with this, I would say that metabolic syndrome with increased sympathetic drive, again beta blocker would come in the forefront.
Yeah, so Indians definitely do have a hypersympathetic drive which is there prevalent, and I'm sure most of you would agree and have been using beta blockers for that reason, which is not the thing. Now, I would come to the second part, and Dr. Mahesh Shah said that, in my absence, obviously the part can be easily be taken by Dr. Karnik only. So he talked about the CT calcium scoring, and one point which was there in the calcium score of 0 to 100, which he is the first one as abnormalities is there. So where one will be, will you put all these patients on statin, one, and would you like to put them also on antiplatelet like aspirin? The patient is asymptomatic, patient have all other parameters are well controlled. So we are not talking about that as a lipid lowering therapy. Forget that, because presume his lipids are well controlled. Only accidental detection of coronary calcium score of between 0 to 100. So more than 0, so it's not 0.
Yes, the moment person has calcium score of whatever, which is not 0, that means he has some plaque somewhere in the coronaries, and then aggregate score is 100. So I would probably also go for additional screening test to see the risk enhancers. There are risk modifiers, risk enhancers, which will include lipoprotein A, which will include ApoB more than 80, so on and so forth, or even triglyceride versus divided by HDL ratio, which gives idea about the LDL particles, because LDL, small dense LDL is also very strong causative factor. So triglyceride divided by HDL, if it is more than 3.5, that will again indicate that he is more likely to have more small dense LDL, which can also be seen with ApoB also. So these are all the risk enhancers. So I would go for that. And secondly, of course, the family history, that you said that he is totally asymptomatic. So probably then I would go by family tendency. And then I would put this patient on statin. Only thing, if he has some renal dysfunction, if he has some parathyroid dysfunction, then these are the people who have false positive calcium scoring, because medial calcification can occur in the renal patients, and then which will give positive. People who are otherwise taking statin for a long time, statins also reduce even small deposits of LDL within the subintimal region, subintimal coronary arteries. So that will secondarily go healing, and it will produce false positivity. So these are the patients which I will exclude from continuing or escalating statin therapy.
Okay, and what about antiplatelet?
Antiplatelet, I will be more in favor of, because the moment he has calcium, and on the top of that, if he has carotid intima media thickness also more than 0.9, then he already has, this is established atherosclerotic disease. So then he becomes a straightaway candidate. It's not for primary, but he becomes a candidate for secondary prevention.
Okay, so whenever you are doing it, then need to be considered little more seriously. You are detecting preclinical atherosclerosis and could be treating on that. And that is what the concept is now when we are looking at it, looking at a holistic approach. Kriplani sir mentioned very well about the kidney components and the preventive aspects. So up till now, it was earlier the trend which was there, and we have seen as a clinician that whenever there is an elevation of creatinine, if then our nephrologist, you do a typical pattern. If we have started with RAS blockade, the nephrologist will come and cancel it, and if it is not added, they will add it, and that was the standard principle in the past. Now as you said, the concepts are changing. In fact, we are using these drugs as a nephroprotective agent. So, sir, any creatinine level where you would definitely say that, no, this patient, I need not be put it, or at any level you will put and monitor the rise in?
Yeah, I think your point is well taken. There is a changing scenario. And it's changing because we itself know that we are not using enough RAS blockers. And the reason is, one is that you have to face the patient for the creatinine rise, which some will take from you nicely, some will not. And also now the potassium is becoming less of an issue because we have got potassium binders which can be used lifelong, except that they make a hole in your pocket. But then ultimately what comes to the rich will come to the poor, somehow or the other. So that's a minimal limitation which will change. Already all the barriers are coming down. You see in every drug, the Indian copycats are doing good business. Very soon it will happen. So that potassium restriction is coming out of the way. The creatinine problem also will come out of the way. Now I tell you, this is a chap in Singapore called Dr. Lai. All right, he is a nephrologist. Every good guideline tells you do not use ACE inhibitor and ARB or two RAS blockers together. If you go outside his office, there's a line of 10 Indians waiting, and he gives everybody aliskiren and valsartan, and also and the creatinine goes up. Many of my patients are with him, and they come and show me, sir, see, and they're quite happy. I'm telling you that many times guidelines can be wrong. We used to also use in nephrotic syndrome 2 RAS blockers. But because this limitation came, we couldn't use it. We are afraid in India not only of the patient dying, but also of ourselves dying of heart disease because of legal issues and all. And really we are worried. That's the truth. That today I give somebody what he is giving, aliskiren and valsartan. Do you think they'll forgive me when every guideline says don't use 2? So that is also now, I'm able to convince my patient, look, that. But recently we were publishing a data on central aortic pressure. And we found that out of our first 50 patients, only 9 were receiving RAS blockers. The others, all CKD, were receiving non-RAS blockers. So that is true that the nephrologists, when you write it, I cancel it. But it's wrong.
Yeah.
If you cancel the RAS blocker, you will see there is something called stop ACE study. What happens is when you give RAS blocker, many other cytokines develop. But because the 82 receptor is blocked, nothing happens. You stop the RAS blocker and all those cytokines make a rapid progression of CKD. So the impulse to stop RAS blocker is not justified. You have to find a way to do it gently, reduce it, go back with a small. But if you do that, your proteinuria will suddenly jump up, the GFR rate of decline will jump. So we are also improving ourselves. But we need that protection, which luckily he's sitting in Singapore and giving all these. And he's doing roaring business. He does transplant also. And he's a damn good doctor, I can tell you that also. So, these are the limitations that we have. These are the limitations you'll have. But you don't have to answer. I have to answer. Being, the senior most person is, how did you do it? I won't be able to do it.
So sir was referring to aliskiren is a direct renin inhibitor, and obviously with all the guidelines recommendation, 2 RAS blockade therapies should not be used together, and that is how we came about AC inhibitor, ARB, or even direct renin inhibitors.
On target trial.
So which is clearly shown that should not be used, and that is what said. So
Now.
so we have got that, what is more important, it's not the number game. You are looking at the benefits or protection. What is getting more benefit? So one is, of course, sir, as was mentioning, people may be skeptical about. We need to convince them and explain them about whatever rise in creatinine and which is happening. I would come now to Dr. Manoj, sir. When SGLTD came from the diabetic treatment, and again at that time, there has been cases where people had slight elevation on creatinine in a few subset of patients which were happening, and those who are very thin, they would come back and tell you, doc, you started this medication and look, now you worsened my kidney, because they will look at creatinine, which is there. So have you come across, and what do you tell, your approach towards that?
Fortunately, this fear has been laid to rest. This business about, initially it was with ARBs and now with SGLT2 inhibitors, that they can cause acute kidney injury.
Right.
But we realized because of changes, so with the ARBs, it's on the efferent side. With SGLT2 inhibitors, it's the afferent side. It reduces increases the tone on the afferent arteriole, reduces GFR, the glomerular filtration. So the GFR goes down, which is protective. So as sir very clearly said, the creatinine may seem to go up, the GFR may go down one number, but the albuminuria comes down significantly. And over the years now, 52 weeks, 104 weeks, the GFR decline is much less than what is seen in the placebo-treated group. So this fear has been now laid to rest.
Correct. So that is how when the SGLTD we had, it was obviously the baby with the diabetologist and endocrinologist, and then of course the cardiologist came in the picture. He said, no, now this is our baby. They wanted to be the parent for that. And subsequently, now the nephrologists are also saying, hey, it's our baby too. And we are also going to take care, because these are the drugs. And then subsequently we have GLP-1RA, which has shown over a period of time. Now we have a data not only from metabolic perspective, but from the renal perspective, from the cardiac perspective, this has shown. So the spectrum has totally changed. So we are not just, no more calling them as anti-diabetic drugs. So these are the therapies which are having a CKM used, what we are now calling as a CKM syndrome. So I would ask Kriplani sir, about telling people that, I'm sure you see, being such a senior practitioner, you look at the various aspects. Are there any challenges people where the patient would say that, like, okay, you are to manage the kidney issues, and why you are talking so much or evaluating from the other perspective also? Because now obviously that becomes a very crucial aspect. So what are the challenges which are there when we have to go beyond kidney and looking at the complete spectrum, holistic viewpoints?
There is only one challenge: time. How much time do you give your patient? My patient spends a whole day in my office. I get someone to look at every page. And once he's analyzed, our patients are very intelligent. They don't cheat on drugs also. If I show you prescription of 31 drugs in a transplant patient, he takes every drug, because the word kidney frightens people, and they don't cheat on drugs. They also understand damage. But you should have time. You should see what the creatinine was doing and which drug did it. And then you, as I said, don't go all in. I don't call people after 3 months. I call them after 5 days. Show me the potassium. Phone me. I have a homeopathic doctor who sees and says, potassium theek hai. That's all. Then on the phone it will come. But you have to, again, that last slide is the most important. You don't gamble like a gambler says, all in. Don't do that. Of course, the more attention you pay to the patient, the more rewarding it is. And that is true, that it is a challenge, because every patient comes to us with the hope that his creatinine will come down, not with the hope that the creatinine will go up. And so, if you don't tell him in advance, then your reputation is at stake.
So that's I'm sure would be quite often a challenging task.
Yeah, every patient is like
for them that will come. And you said that obviously you need to go sequential or careful when you are talking about the renal protection. When it comes to Rajiv Karnik, he would say hit early, hit hard, and hit simultaneously. So like for example, I'm sure if it is for a heart failure or for a particular patient with a CKM high stage, you would be aggressive in starting all pillars of therapy, right? So may not be down 4 also or 1-5. So do you find challenges or difficulties in starting all the therapies simultaneously in such patients?
See, as far as heart failure goes, I don't find any challenge because we have, I have kept some of the slides on my desktop itself, and I show them that what strong HF trial had shown, that within 180 days you get 8% absolute reduction in the event of heart attack or death. I mean, that's very impressive statistics. So such slides in your desktop, which you can just show them that this is what you are going to get. And in fact, what you are getting is if you don't do it, you are likely to die. That fear makes the patient accept it. See, for example, even in the heart failure, same thing happened. That initially when the early treatment was proposed by Aguirre Carlos from Santa Cruz, Lisbon, Portugal. So he said time is prognosis, just like in acute coronary syndrome, we say
Heart
time
is-
is muscle. So see, he said time is prognosis, nobody paid much attention. Then Subodh Verma from this thing, USA, he said, when will you start? Will you start it one day or will you start it on day one? You should start it on day one, nobody listened. But when Stephen Green came, and then he showed that if you don't treat it, you are likely to cause so many extra deaths. So that created immediately fear in the minds of the physicians that if that categoric presentation is there of Stephen Green, that you might kill the patient if you don't do it. So that's an act of omission, like act of commission and act of omission. So if there is an act of omission which has killed the patient, I might get medical legally sued. And then that made the things very easy, this thing, everybody started giving all these drugs together. And we have enough data that they should be given and you can save lives.
And Rajiv, if the creatinine goes up, send him to me.
So, Dr. Chadha, now obesity, which earlier was, looked upon, okay, lose weight and all. Now, if you see the route for CKM, which starts with, being obesity, subsequently going to diabesity, then you have a nephropathy, you have cardiovascular disease. So when you are treating from diabetes perspective, I'm sure now obesity, which has been looked upon as a part of your metabolic syndrome, and you are treating primarily for it. We have the therapies which are now aggressively, I'm sure, which has come up. You've got a GLP-1, you've got a dual therapy, and now you've got a triple therapies which are available with that. Now, with the recommendations which is there, if you see people with the underlying, the existence of ASCVD, this would be the therapy which would be first preferred. So would you go and do you find difficulty in practicing that way, or is it well accepted?
I think we've all accepted it, and more than we, the patients know what they want. So very often the patients come saying that I need this product, and it's gone one step further, I want this brand also.
Okay.
Yeah. So the long and short of it is that we understand the importance of looking at obesity as a disease, as serious as what Dr. Karnik or Dr. Kriplani have been talking. And fortunately, you have tools today. Not like good old days,
Yes.
you need to exercise and diet and nothing else to be offered.
Correct. And for diabetes, it was the metformin, which was a therapy till 2018. I remember the first time any guidelines which changed the therapy, it was 2018 when EASD mentioned SGLT, which was mentioned as the therapy which can be used with the patients who are having a pre-existing ASCVD also. I think this is showing time's up, so we take up the questions. Yes, sir, you were, I know, sorry for keeping you wait, but I never wanted you to stand for so much. That's why I said you can have a seat. Yes.
My question is basically to the panel. Now we are looking at apoprotein A and B. There's also a ratio of apoprotein A and B. First thing is sensitivity, specificity. And is it worth doing?
See, ApoB normally, the ratio is always given, but I see more often the ApoB actual level. And if it should be less than 80 milligram %. The moment ApoB is more, that means there are more, each LDL particle will have one ApoB. It is 1:1 ratio. So more the ApoB, per quantum of whatever, per cc, per this thing. So more the number of this thing LDL molecules. So it's not the total LDL, how many milligram percent which is important, but it is the ApoB. If the number is high, that means there are small dense LDL particles which are much more in number, and each particle is having one ApoB, and that is producing this ApoB more than 80. So that would immediately start getting more aggressive, moderate intensity or high intensity statin.
Yes, Dr. Dargad, sir.
So, Kripalani, sir, you mentioned about the doctor from Singapore using allicrenin and valsartan together. What was the incidence of hyperkalemia in these patients? Any data you have?
See, there's, to be honest with you, I have few patients who have enough faith to come and show me their data. But I don't actively treat them now because they have faith in that man. So I can't really give you data.
Mostly he's a transplant
but he's
man.
a very,
No, he's very
I
good
can
doctor,
tell
we
you
know.
they are satisfied and they are alive.
Yes.
Let us be
So
honest.
proteinuria definitely
I
goes down.
accept that someday this man, if he has, I'm sure he has data ready, he will publish it and show. Like Dr. Mani said for years that like this metformin does not cause acidosis, and it was only fenformin. But others poo-pooed it. Ultimately, it came back in CKD. You could use it up to GFR of 25.
Allicrenin is not available in India now, actually.
Which
Allicrenin
one?
is Allicrenin
Aliskiren?
no
Yeah,
more.
it's not available.
Not available in
It's
India.
available abroad.
Probably banned.
So
And
it's
now-
a matter of time that people overturn what is written in the guidelines and show
only
the
thing-
truth. So
only
I
thing
wouldn't
we'll
be
have to take care of
surprised
the-
if he has got data and one day he publishes it. I hope he does because he has the guts to do it. So he may be able to publish it also. I don't have the data.
Okay, any other questions? Quickly, that would be the last question because I can see, the impact of the talk was so much. People were talking about the lifestyle modification, control of lipids, and our delegates were really enthusiastic. How can they best increase HDL quickly? And that's why I can see suddenly the rush going over there, thinking to raise the HDL so quickly. So last question over there.
Coming back to the use of ACE inhibitor or ARB in kidney dysfunction, you see if the creatinine level goes up when we are using such patients. So what literature says that up to 30% rise is acceptable. Beyond 30%, you should stop. Now the other question is whether we can introduce this in a kidney patient or not. So what literature says that if the eGFR is less than 30, then you don't initiate on ARB and ASB unless the patient is on dialysis. What are your comments?
See, these arbitrary values are written from multiple papers. Now, in a study, it is about 7 to 10%. But you know that studies are made to fit what the thesis was. In reality, when you calculate, you get a huge scatter. But the important thing is, if you are convinced that the creatinine is not as important as the USCR, if you have brought that 5 grams protein to 1.2 grams protein, you've done your job. And that is what I'm seeing in the patients who come back from Singapore. They go to me, from me at 5, come back with 7 but very happy. And when I say you're happy, they see my proteinuria. The proteinuria is coming down. So, but you have to have the guts to be like Dr. Mani and say, I'll use it. I'm not so courageous. He's my teacher. I bowed my head to him. He did it. He used like this metformin in a big way. And nothing happened. And then the whole world recognized that nothing happened. And see, this man is also doing that. But he's convinced these rich people to accept a 7 when they were not accepting a 5 from me. So figures are for the books. The truth is how you handle the patient.
So, sir, I think one point is when you're talking of creatinine of 5 and a creatinine of 7, what is the functional difference?
Difference is 4 or 5
Yeah, exactly. I
milliliters.
mean, the numbers look very big, but when you look at the clearance.
But to the patient, it is, such a big thing.
The bottom line is we don't have to look at the number game, which is the most important. So I would definitely like to thank all our panelists. Please give them a big hand. Dr. Ashok Kripalani sir, Dr. Rajiv Karnik sir, Dr. Manoj Chadda sir, and of course Dr. Mahesh Shah has left. He had to go for some other meeting also. And for CKM, you know, if it is the we physicians are the one gatekeepers to them, and interdisciplinary treatment is the definitely the key to it for better patient management. So thank you so much, and we'd hand over back to the team for the further vote of thanks. Thank you.
Thank you. So thank you, Dr. Ketan Mehta, sir, for wonderful moderation and all our expert panels for valuable insights. Now, as every good thing comes to end, I invite Mr. Varun to give final vote of thanks.
So first of all, we would like to extend our heartfelt gratitude to each one of you for taking some time out and being present here for such insightful sessions and inspiring sessions taken by Dr. Ashok Kriplani sir, Dr. Mahesh Shah sir, Dr. Dr. Manoj Chadda sir, and Dr. Rajiv Karnik sir. I would also like to thank Dr. Ketan Mehta sir for being a part of a wonderful panel discussion session, and Dr. Jayesh Lele sir, the chairperson of IMA, for making his valuable presence in this meeting. I'm sure that these insights will be useful in your daily practice, and we commit to provide you the best scientific evidence from time to time. I would now request all of you to join us for tonight's dinner. Thank you.